Great. Thanks, Adrian. Real pleasure to be here with you and with everyone tuning in. We're so very excited to be working with Rupa and working with all of you and have our tests have access on the platform. And hopefully you're finding that very easy as well to see us there and to order tests as needed. And we're going to go through some things on with regard to the testing. But as Adrian and I were talking about before we started this, and this is, it's like a didactic kind of talk about testing, and everyone joining probably knows a lot about breath testing specific, primarily to SIBO, but also some intolerances. However, what we do different is matching clinical impressions to the breath test results. We don't just do breath testing and send the result out and it's a positive indication or negative indication. There are many tests that do that. We'll send a result and it's pretty straightforward and exactly what you expected to see based on your clinicals. But then there are times when maybe it doesn't match. And so we should have a conversation, because if you do this testing right, and we're going to talk about it, if you do it right, it's binary. Our bodies don't produce these gases. They come from bacterial fermentation, archaea fermentation. And that's where we get the hydrogen or methane gas. So if everything falls into place, we're going to get into the details of that. We should always be able to match with what you're expecting to see. If you suspected SIBO or an intolerance, then we should have the data to back you up on that. So feel free. I know that we have a consult ability through Rupa, through Calendly. Feel free to book a time that works for you, or have us call you when you have a question on any type of result, or what type of test to order, or, hey, I did a test with another lab and hey, I'd like to talk with you about the result. We're here to help at any time. So let's just jump right into this. I'm going to go high level through these slides. I think the real value in this time that we have together are the questions, because that's where we really get into the meat of what's on your mind. And if you have the question, I'm sure everyone else is thinking the same thing. As I mentioned, we're talking about matching breath results to your clinical impressions. It all starts with the importance of accurate sampling, right? To be sure that we're measuring true human lung air, we need a good collection device. The devices that we use are the Quintron brand of collection kits and machinery. What we were talking about here is matching the clinical impressions and the importance of the testing. So let's go into it. We know it's important to test. Before I started the laboratory many years back, and many of you probably recall this, there were just about every office I knew was, if you suspected SIBO, you just went ahead and treated it based on the clinicals. And the reason for that is the testing wasn't as accurate more than a decade ago. And when I was dealing with, the reason I founded the lab is I was dealing with SIBO in my own family, my daughter, and we were sent to the Brigham and Women's, perfectly great hospital. But you had to schedule time. You had to go down into the city. You had to go down into the basement where the lab was. You were there for 3 hours. It's very inconvenient. And then with my diagnostic background, I uncovered through the process that it wasn't very accurate. And that's why a lot of clinicians weren't testing back then. But we've evolved. And as breath testing for SIBO and for intolerances has grown immensely since then. But we want to test to confirm that we are dealing with the condition. And again, probably focus on SIBO. So SIBO can look like a lot of things: fungal, Lyme, mold, parasites. So we want to be sure not only are we dealing with SIBO or an intolerance, but with SIBO, do we have methane on the test? Because as you'll treat differently, oftentimes, if there's methane present. Do you have those chronic postprandial SIBO symptoms? Is that how the patient's presenting? When I say chronic postprandial SIBO symptoms, I'm talking any day of week, any type of food, any time of day. Because if you have an overgrowth in the small intestine, it doesn't matter the time of day or the day of week or the type of food. The patient is going to exhibit your symptoms. So that's from a clinical side. That's what we want to hear when we're suspecting SIBO, and then we test and confirm it for you. So we were talking about the importance of accurate samples. You have to have the good, and that's where we cut off with not sharing the right screen. So we use the Quintron brand of equipment. Why? For those of you that know the equipment, it's a vacutainer. The evacuated test tube is crimped, rubber stoppered. The device is like the vacutainer where the needle punctures the rubber stopper, that test tube is never opened up to room air. Even when it gets back to the lab, it's punctured again, it's vacuumed out, then it goes through the machine. So you don't have that room air contamination. And that's why with some reports that you may have received that didn't match potentially the clinical impressions, that's because it potentially could have been a collection error, both whether it be from the patient or the equipment being used or the laboratory. So we'll talk about that. So the collection device, and then I briefly mentioned improper collection. So that can happen sometimes, even with this device. So a patient, and this is the struggle, the biggest struggle, is getting that human lung air into the collection device, in our case, the glass test tube. And so using this vacutainer type of system, that allows for the efficiency of that. But we also take it a step further. You may have seen on some reports, whether it be Aerodiagnostics or others, that some of the labs, and they should, measure carbon dioxide. Why? Carbon dioxide is found at constant rates in human lung air and trace amounts in non-human lung air. So we qualify each test tube to be sure that the CO2 content is accurately reflecting that the contents are the human lung air. So how can they do that wrong? So a patient, they're asked to just take the device, put their mouth on it, and exhale normally. Some patients, because the device has a blue bag attached to it, they feel like they have to blow up the bag. They feel like the specimen is going in the bag. And the specimen isn't. Actually, if you look really closely to the bag, there's a slit in it or a hole. It's meant for flow. So if a patient were to inhale deeply and then exhale forcefully, that inhalation that they did, that extra inhalation is mixing up their lung air. So that's where you can get false negatives. Okay. So the part of this is training, and I'm going to tell you what we do with regard to that, the patients. And part of it is the patient using the device correctly. And then, of course, what we do in the lab. You can have some issues with some patients, whether sometimes kids will puff, sometimes, as I mentioned, a deep inhalation. There are a couple of things like that, but generally speaking, we don't have a lot of issues with that. And the reason I feel that is the case is the model. So when you place an order for the test, that order is placed and that kit is shipped out either the same business day or within 1 or 2 business days following that order. When that occurs, it goes either FedEx or UPS 2-day business service. When we know the kit has been delivered, we actually proactively reach out to the patient and offer to assist with any questions that they might have. Now, you can also on your end encourage the patients to call, because that's helpful when we're connected with them to answer their questions so they don't feel like they're overwhelmed. Additionally, you'll find that we're available business hours, 9 to 6 every day. But if we need to do anything after hours for any of your patients, we're always happy to help them. So feel free. And of course, I know through the Rupa platform, they're always available to answer many of the questions. Okay. So let's move on here. So the instrument. So we use solid state sensor machines that measure these gases. So if you were to come to the lab, what you'll see is a machine, almost like the old desktop computers that you see, like a big rectangular box. Inside are these sensors. And as I mentioned, the test tubes are evacuated and there's an alveovac, a machine that brings the sample out, puts it through the device, goes across the sensors, and that's how you measure carbon dioxide, hydrogen, and methane gases. And then we put it through the interpretation process. So if the patient does what they need to do from the preparation and the collection, and by the way, on our website, on the landing page, right at the bottom are 2 very short videos. One is the collection process. It's very clear, very concise, and it shows them how to use the device. So that's another thing you can point your patients to. But it's important that you use good machines and operate those machines accurately. We're going to talk about that here in a second. We talked about why testing. We all know, especially with SIBO, we know what the downstream effects can be to a patient who is left untreated. So we want to be sure, if you suspect it based on the clinicals, that we're confirming that for you or validating that it's not the case. So when should you test? Okay. And which test should you choose? So the patients, again, they present to you with the postprandial SIBO symptoms any time of day, week type of food. That's what we were talking about earlier. If they have intermittent symptoms, it's less likely to be an overgrowth. If they say that they can get through with this food or that food, or I only feel it at evenings or I only feel it on the weekends, probably less likely to be SIBO from our opinion, from the 100,000 tests that we've performed over the last 9 years and having conversations with all of you and learning from you as well. But if you suspect SIBO, this is incredibly important part of what we'll discuss. If you suspect it based on the chronic postprandial SIBO symptoms, you're going to test. And then if they're positive, you'll obviously treat the patient. In the kit, it'll say retest 14 days later. Most of the SIBO thought leaders across the globe will test around 10 days post because they don't want the bacteria, if it's still there, if you didn't get it all in the first treatment, they don't want it to repopulate. There are some that will test within 5 days, some that will test the very next day. There are several opinions, and I won't get into in this forum which one, who's doing what and why, but I can always speak with you offline on any of those if you want to understand why different people are approaching it differently. But essentially, we want some passage of time. So typically it's around 10 to 14 days. We want to see if the treatment worked. In the past, we know that they didn't test. We talked about that earlier, but if they did test, they didn't retest after treatment. So if the patient presents, they have all these symptoms and it's chronic, you test, you confirm it, you treat, and then they tell you they're feeling better. So why retest? Why spend the money? And you can use any lab to do the testing. I'm not saying this because we want more tests, but the patient will end up spending a lot more money if they don't retest, especially if they were positive. Because what happens most of the time is they've been sick for so long that many even have forgotten what good feels like. So if they had constipation or diarrhea, or they were just bloating and that bloating is now reduced, or the constipation or diarrhea went away, they feel like a million times better. So what do? I don't need to retest. But then what happens? If there's some residual bacteria, it repopulates and now they're back to seeing you, back to doing initial tests, back to the treatment cost. So to be most cost effective, suspect it, test, if positive, treat, 10 to 14 days later, test again to make sure that it's all gone. That's what that I can tell you. By and large, I see this with various large clients. We do a lot of work in Europe, and some clients will really encourage retesting and some won't. And I see these patients returning, the ones that don't retest. I see the patients doing a lot more tests later down the road just because of what we just discussed. So anyway, just a few thoughts on that. Okay. This kind of died down over the last year, but it always rears its head. Should I use glucose or should I use lactose? And we have some slides on this, should I use fructose for a SIBO breath test? Now, this is my opinion. If I didn't feel that both were accurate, I would not offer both. Both are accurate. Now, there are a lot of opinions and a lot of well-founded opinions, and there are a lot of researchers that have opinions on which product to use, but the data is sufficient and it's there and it supports the fact that both are accurate. In my opinion, and based on what I've seen, you're not going to miss a distal infection with glucose. The argument is that it's absorbed in the small intestine, so you could miss a distal infection. The fact is, though, that the data doesn't support that. It might be someone's clinical impressions, and that's fine. It's not there. So both are very good. If I were to be asked, it's funny, it works in different markets. It works differently because if you're in Europe, by and large, they're using glucose. And then if you're in the US, it seems to be lactulose. If you are a GI, you tend to use glucose more. And that's, again, very broad statement. I'm sure there are many GIs that use lactulose, and we know of some, right? But it's really opinion based. The substrates are a food source. Our bodies, as I mentioned earlier, don't produce these gases. So if the patient preps correctly, we're going to talk about that more in a minute, they're removing food from their GI tract. The small intestine is not sterile, but it's supposed to have less than 10 to the 3 colony forming units of bacteria. So very small amounts of bacteria in the small intestine, whereas the large intestine, more than 10 to the 12, a lot of bacteria. So if the patient preps by doing a very strict 24-hour prep, 12 hours of a limited diet, followed by 12-hour strict water fast, then there should be no food in the GI tract. No food, there should be no gas. So when that patient does their first breath collection, their baseline, there should be less than 10 parts per million of hydrogen or methane gas there. There are good reasons for an elevated baseline. We can talk about that. We'll talk about that later here. But by and large, you should have that. That's what we should be doing. So now what happens after you do the baseline sample? Now you drink the glucose or the lactose, which just becomes the food source, goes through the 23 plus feet of small intestine. If it finds bacteria or archaea, it's going to ferment, and that fermentation process yields the gas. The gas diffuses through the blood and exits via the lung air. And if collected appropriately with the right device, it goes into a closed capture device and it's measured accurately. So this being a food source, and I'll just a quick conversation on this glucose versus lactulose. There were a couple of very well-known SIBO thought leaders that were challenging me on the glucose. So I said that I would let them test 5 patients and do a glucose and a lactulose for each patient. And you can blind it. Don't tell me, send it my way. And I'll show you that we're going to get the same results, whether it's lactulose or glucose. And guess what? I did it for 5 different clinicians, 5 patients of theirs each. And yes, everyone matched up because it's a food source, and glucose isn't absorbed in the proximal bowel, small intestine. It makes it through. We're even finding some in the colon now. But so the argument to finish this up was that glucose would be absorbed. So you got to use lactulose. But then the argument for those that use glucose is lactulose is like a laxative that increases gut motility, and you'll get false positives, which can be true. So that's why, and again, we're going to get into interpretations and the differences, but that's why we look at the first full 120 minutes and we look for gas production. And then if we find it and it's only at the distal end, 120 minutes, then a call is made or a reach out is made to you as the treating clinician to discuss the patient if you want. The fact is, there are a lot of good reasons to have a distal positive. The transit time studies for lactulose were as short as 40 some minutes to as long as 140 some minutes. So we all know that patients differ. So we want to look at that first 2 hours and then challenge with lactulose those ones at that distal end. And then the last thing I want to say is, okay, if you were going to do a test on yourself or a family member, which one would you use? And I would tell you, I'd probably use lactulose, but the reason I'm doing that is I'm selfish. The fact is, when you do a test with lactulose, if it's negative, you're still going to get gas at the end of the test in the 3rd hour. That's because the lactulose enters the colon where we had that more than 10 to 12 colony forming units of bacteria. So when I look at a result, I can say, oh, we have a nice low baseline, patient prepped correctly. We have good CO2, patient collected correctly. The patient drank the lactulose. We know that because in the last hour of the test, that lactulose made it to the colon where there is bacteria. And so we know we have a solid test. With glucose, if I have a test result, we don't reach out on every negative glucose test. We can't. However, when I see a glucose result that has very low parts per million of hydrogen and methane gas, my antenna's up, because you would be shocked at how many times patients have troubles with doing things, following directions. So sometimes they don't drink the substrate. With a lactulose one, it stands out because you don't have that rise at the end. But with glucose, if it's really low numbers, I want to call and say, hey, before you think of this as a negative, can you check with the patient, make sure that they drank the glucose and mixed it correctly, because it's dose by weight to make them comfortable. And so I would choose lactulose just because I know everything is buttoned up from a quality check standpoint. Okay. All right. So here we're talking about Dr. Horelek, and many, I'm sure, if not all, have heard that he's a fantastic researcher and has done some work with using fructose. And he did it within 115 patients of his own. And you can see the reasonings here. I'm not going to read the slide to you, but he favored evaluating this in his patient population. And here's the results. So in his study of 115 of his patients, if you use lactulose breath test alone, 73%, so 84 out of 115, fructose only 85 were correctly found on the test and from his clinical impressions. If you did lactulose and glucose, 76, and so on. So about a couple of years ago, I think there was a recommendation coming out of his office, or he was speaking to this, where I think he was saying you should do fructose and lactulose and try maybe all 3 tests. And so we all know that's not something patients can do. That's very costly to do that. I don't particularly feel like you need to do multiple tests to determine If the test is done right and the patient does what they do right, what they're supposed to do right, then you're going to get an accurate result. In my opinion, I feel like we match, I can count on one hand out of the 100,000 tests that we've done that I feel I've had a conversation with a clinician where they said, I'm not seeing that positive or I'm not seeing that negative. But with this, with Dr. Warlick's work, many clinicians are really taking a consideration on using fructose. So here's the trouble that we have. You and your office can do anything that you want to. Obviously, if you wanted to order a SIBO test and hand them fructose, have them buy fructose online, you could do that. That's your prerogative. However, from a medical device perspective, FDA registered device perspective, and the lack of formal peer-reviewed published studies, we can't sell a SIBO test with fructose. Know that the data's out there. Happy to offline discuss it in more detail. You can see his approach and some of his findings here. But the good news is, even within his patient parameters here, all three do a very nice job. And I feel fructose has a place in the future, and maybe someone will do some of these studies that we can then make that offer available to you. Okay. So before I get into some of the interpretations, there's one thing that I want to relay. These kits that you order, the tests that you order, the kits go out to the patients. Each kit is going to have some instructions in there. And the instructions that Quinton got approved when the FDA registered their device says that if you as a patient have diarrhea, you should wait 14 days. That is not an issue, particularly with SIBO. So know from me, and I'm happy to get into in more detail. I can't tell you why that was put in there. What I can say is if a patient has diarrhea, it is not going to impact the small intestine where it would lead to a false result. Where potentially, if you have very heavy diarrhea, the patient, and they're doing an intolerance test, maybe that would impact it. Why? Because let's say you have really heavy diarrhea, and let's say that heavy diarrhea was actually flushing the large bowel of bacteria. A SIBO test, we're looking for gas within the first 2 hours early. All of our tests are 3-hour tests, the only way to do it accurately, in my opinion. But we're looking for gas early. But with an intolerance test, we're looking for gas late. Why? We want to see if that substrate, whether it be fructose, lactose, or sucrose, made it to the colon. So we want to see, did it enter the colon? And if it did, then we would get gas. It wasn't broken down. The sugar wasn't broken down, so it made it to the colon. So if you had heavy diarrhea, then maybe you can get a false negative. But with SIBO, I particularly would not be concerned. So you can let them know that they might see that in the instructions, but it's okay. Okay. So let's get back to interpretations. I was thinking there was something else that I wanted to say on ordering in the kits, but if it comes to me, I'll bring it back up. So this is a hot topic, and probably we could have spent the whole time just on this, but I'm just going to go through it. From my perspective, there's 4 basic approaches to interpreting these data. The good news is you're going to get all of the data. You're going to get the carbon dioxide numbers. You're going to get the hydrogen and methane numbers. You can interpret it any way you want, regardless of what we put on that result, which I highly encourage, by the way. The test results should accurately match your clinical impressions, but only the clinician makes the diagnosis. The test should never be a diagnosis, in my opinion. But the one that we use, the interpretive approach that we use at Aero Diagnostics, was based on Dr. Lyle Hamilton's work in breath testing gastroenterology. He's the one that founded this whole process of breath testing for malabsorptions and for bacterial overgrowth. And it's markedly different than some of the others. That was the basis for the Rome consensus. It's very similar. Everyone knows that the North American consensus came out in 2017. I don't favor that one, and for a couple of reasons. But if you were following that, you could use that same approach and look at the data on your report, and we can make a determination based on North American. So if you say, no, Gary, I don't want to use Hamilton and Rome, I want to use the North American, what would the answer be if it were that? And I would give that to you, tell you what it is. The basic differences are from the first 2 bullet points here are we're looking for a rise with lactulose. It's different for glucose. With lactulose, a rise of 20 parts per million of hydrogen within 120 minutes, methane 12, a rise of gas, and not from baseline. A lot of labs get that wrong. In my opinion, get that wrong. You're looking for just a rise. It can come from baseline, which typically it does. It can come from test tubes 2 to test tube 4 to from test tube 3 to test tube 7. But you're looking for a rise of gas. Why? If you think about it, they prepped correctly, then they drank the substrate. That substrate goes through. It's going to start feeding bacteria. So it should be a rise of gas, not just a certain level of gas and not a decrease of gas. And then we also look at the combined gases, which the North American doesn't do. And there's some arguments. I've watched some things online about this, but the fact is methane impacts your hydrogen. And so the reason for the rise of 15 parts per million or more for a combined gas is that the methane is essentially blunting the hydrogen a bit. Some don't use the combined, and that's fine too. Use the collection. If we're only positive result based on combined, you can say, oh, I'm not going to use that. And that's fine as well. Okay. With glucose, it's a rise of 12 parts per million or more in all three. As the North American also does the 10 parts per million of methane anywhere on the test. And that's fine. We don't do that because in my personal opinion, I think we would have too many false positives. However, there's some data and I'm open to looking at that and considering it. But when that lactose or glucose goes into that colon where there is all that bacteria, now the comments are, okay, it's EMO, it's intestinal bacterial overgrowth. Okay. I would like to see multi-sites doing some studies on that and seeing if we're seeing that versus seem to be centered on 1 or 2 sites at this point. And if that's incorrect and 10 parts per million does indicate an overgrowth, then we should be working with FDA and others to register devices for interpretation, not only of SIBO, but then EMO, because right now it's a SIBO test. So to report 10 parts per million based on the North American consensus, I think it would be very confusing because it's a SIBO test. It's not an EMO test. But just my opinions on that. Again, we can interpret any result. You're going to have all the data, so you'll be able to see it. And I can dig in a little bit deeper on that offline if needed. The other one, the last bullet point was the general approach. What does that mean? What if you have a rise, whether it be North American or the Hamilton Roan, you have a rise of 18 parts per million of hydrogen or 19 parts per million. So are you going to call that negative? We have to. We'll put not suspected because it didn't get to the 20 or more. But there's that presence of gas there. Where did that gas come from? It came from bacterial fermentation. So if you have a patient with chronic postprandial SIBO symptoms and you have a rise of hydrogen of 18 or a rise of methane of 11 or 10, are you going to say no to that? I think that the data is there. It talks to you about fermentation. So you match that with your clinical impressions. And I think that's one of the best ways to go about it. So these next few slides were just the actual consensus and the different ones I just spoke to. And I'm just going to breeze through in the sense of time right here. These are all in here. You'll have access to them, but I have like a bunch of these are some of the reasons like we would reach out or you would book a consult for. What if you have like this one? Check out where the red arrows are. So here you have a test and this is where I was talking about, where it's only positive toward the distal end here. It's where the numbers are really growing is there. So is this the lactulose just entering the colon or a little early? Or is this really a distal infection? Look at that. That's June of 2019. But look, same patient, September 2019 and distal again. And then look, same patient, October, distal again. So this is one where what treatment was it? Just maybe not was a treatment failure? Maybe not. Maybe the patient was feeling better and then it started to return. Why? Some believe that when you have a distal positive, it may be indicating that there's a compromised ileocecal valve. So the patient has an overgrowth. You suspect it. We test, we confirm it. You treat, they feel better. Sometimes they test and confirm that it's gone. And then a few months later, it's back. And is it because the bacteria is growing up through that compromised valve? Is, visceral massage of the ileocecal valve warranted? So there's an interesting kind of report. Here's one where we're showing a good improvement. So let's say this is your first test result that you get. It's positive for hydrogen and methane. And I'm showing the red arrow there at the methane, because keep an eye on that when we switch to the next one. Look at not this, not the rise, but look over here at the 15, 19, 23. Now look what happens now. Now it's still positive, but look, the methane's all been but eradicated. So this is good progress. This is good progress. And you would want to know that, because if you just got another positive, you might be thinking what I'm doing isn't working, right? But it is working. You reduce the methane. Sometimes when you reduce methane, hydrogen comes up. In this case, it didn't. It went from 69 to rise to 46, but sometimes it can pop up when you free up the hydrogen from removing the methane gas. So anyway, that's one. Here's a really unique thing that we've been doing for the entire time that we've been open, and it's based on the data. You're seeing the big black box here at the bottom. Remember what I was saying? We should have a low baseline here if the patient prep correctly. So anytime you have an elevated baseline above 10 parts per million, the first question to the patient should be, did you follow the diet? Did you do the water fast? And in this case, I'm going to tell you that the patient will respond, yes, they did, because bad prep usually is a high number that comes down. With this, and you're seeing the reference for it, you're seeing an elevated baseline that goes up in test tubes 2 and or 3 and then starts to come down. That is indicating that the fructose that was used for the fructose test was feeding some bacteria proximally. So this is a situation where you might be dealing with a patient that's dealing with SIBO, even though you were doing a fructose test. But then lo and behold, the second arrow at the bottom, here's the fructose now going into the colon, indicating that the body didn't break it down. So fructose intolerant. So on our intolerance tests, you're going to know if there's the potential for SIBO based on early gas. Okay. And why do we have an elevated baseline sometimes? I told you we would talk about that later. And others in 1975 published in Lancet, attributing elevated baseline to those patients who prepped correctly due to glycoproteins in the intestinal wall. So there are some very good reasons for elevated baseline. Just always check with your patient or have your staff check with the patient to be sure that they prepped anytime you have that elevated baseline. So this is another, we were just talking about elevated baselines here. You want to check prep again, but here, look over here to the left. We have to call this not suspected, but we have 2 footnotes. And one of the footnotes is footnote number 4. That's what the red arrow here is. It's what we call elevated and sustained levels of gas. So sometimes you don't get a rise. It's just presence of gas there. And that gas is telling us that there's fermentation. So as long as the patient prepped correctly, this is not an uncommon result that you'll see. And when you see that, many clinicians and SIBO thought leaders consider this an indication potentially of slow migrating motor complex. You might choose to also treat with a prokinetic to get that action back again. And we haven't talked about it too much, but here's the carbon dioxide numbers over here. If you see numbers in these cells, that means it passed the test as true lung area. If you see a too high, like down here, or NA, the NA means the test tube was missing or broken. Too high means that it didn't pass the CO2 test. It wasn't consistent with lung air. In this instance, it was colonic. It didn't matter. It didn't impact the test result. So it depends on how many of those we get and where they're at, if the patient needs a retest. But you notice when we put the actual numbers there, I think it's important for you to know an FCO2 close to 1 is a good sample. An FCO2 close to 4 or above is a bad sample. And I think you should have that data. And so that you know if what the hydrogen and methane numbers, if they're accurate, it really matters with the collection device and how it's not opened up to room air at all. Okay. And then this one. So this is what I was talking about before. This is a lactulose test. So why, when that lactulose got down here, well, this is a bad sample, but the 9 and 10, why isn't there gas there? When that lactulose goes there should be gas. So there are roughly 9 common reasons why that can occur. Here they are. We'll share that with you. You have it. Did they drink the lactulose? Did they mix it with water? Was there some flushing effects? Are we dealing with hydrogen sulfide gas? And in my opinion, the only accurate way to know that is if the patient is doing this. We don't offer, and that'll probably be a whole other class. We don't offer hydrogen sulfide testing. I don't feel it can be done accurately right now. And even if it could, in my opinion, I don't feel like it can. There's the issue with volume. Hydrogen sulfide gas should, in my opinion, be measured in parts per billion, not parts per million. Unlike hydrogen and methane isn't produced in our bodies. It comes from bacterial fermentation and archaea fermentation. Hydrogen sulfide is produced in our bodies. We use it for cell signaling. So the real question is, what is the normal level, right? What's abnormal? What's normal? If you don't know that, then how do we know how to judge a result? So if you ask these questions, do you have, in addition to your chronic postprandial SIBO symptoms, do you have peripheral neuropathies, any tingling, numbness, hands or feet? Are you intolerant to light or noise? Do you have interstitial cystitis, so any burning urination, bladder irritation, fibromyalgia, body pain, body ache? Even though ironically less rare, the last question is the stinky gas. Do you have that rotten egg smelling gas? That's sulfur. And I'm going to show you at the bottom of this. I got it from a good friend. She went on sabbatical and did this work. And the reason for those is the sulfur gas works the nervous system. And so that's why you're going to get these types of results. Okay. And we found if you use that on your intake, those questions along with your others, you'll know if you're dealing with that. And then if you don't always have to have a flat line like this, you don't have to have a flat line to be dealing with sulfur, in my opinion. But this is a telltale sign to ask those questions just because. But if you ask up front, then you'll know when you receive your results. Distal, we already talked about distal positives. And then let's just think here, as a rise. Yeah, this is what we were talking about again. It didn't get to the rise, but we had this elevated and sustained. Okay. So this was what I was just talking about with sulfur gas. This comes from Dr. Siebecker. Many of you probably know who she is. So this is a build out of those questions a little bit more. And then this is her opinion. I don't make treatment recommendations, not my role here, but this is what she does. She uses or suggests bismuth either alone or in conjunction with your antibiotics or herbals. And then she has some other supporting it. And here are all the references for what I was just referring to. These are all the science that supports that. And I'll end with this and go to Q&A. I've seen this really align when I have my conversation with clinicians. So if we had a positive or a negative on hydrogen or methane, if they suspect hydrogen sulfide based on some of those questions, and they treat with the way that was recommended by Dr. Siebecker, we're seeing the clinical improvements in those patients. So I'm seeing it live time for over the last 2, maybe 3 years working with this. And at some point, when that type of testing is available through my trusted source, then I'll make that available to you. But at this time, we have to answer those 2 questions. Can you do it? You need a large volume to get it right. And it's a sticky gas. So can you do it? And if you can, what's normal, what's abnormal? So what are we measuring? What's that telling us? Okay. So I'm going to, Adrian, I'm going to shake this back to you to see if there are any questions for me.
Hi, everyone. We hope you enjoyed this class. If you're a practitioner, make sure you go sign up at rupahealth.com. And if you like this video, don't forget to like and subscribe.